And thank you very much, sir, for this opportunity to be able to present this topic, arterial aneurysms. I am Nikhil Danpal, final year MCA student from Stanley Medical College. And before I start, I would like to say that this is quite a dry topic. It doesn't really have much substance in terms of high yield questions for the exams or any things that we can use clinically that we apply on a daily basis. But I think an important aspect of understanding any disease process is knowing the numbers and knowing the epidemiology of that disease process. So this is my attempt at it. So please pardon me if I'm quite boring, because the material itself is quite boring. This is a picture of Stanley Medical College. That's the old colonial building that you can see on the left. And there's an interesting plaque on the right, which is actually on an obelisk, and it has the names of all the surgeons who lost their lives in World War I. So one thing to understand before we move into the pathophysiology and the epidemiology of aneurysms is that the definition of aneurysm is, comes later also, but a dilatation of any blood vessel is an aneurysm. And the most common aneurysms are the ones in the infrarenal aorta, AAAs. In the US, because this is the only data in Rutherford, AAAs were responsible for 9,900 deaths in 2014, and approximately 120,000 procedures were done on AAAs to prevent subsequent rupture. Now, the aneurysmal lesions may be the result of degenerative processes, inflammatory, infectious, genetic and traumatic conditions, etc. So they have multiple complications, the most dreaded of which is rupture, and the risk of ruptures depend on the absolute size relative to the normal diameter of the inflow and the outflow artery from which the aneurysm arises. And there are other variety of factors such as the location, the growth rate, the etiology, etc., which could also dictate rupture or no rupture. And the aneurysm morphology is also quite important. So to dig a little into the history, there is the Ebers papyrus, which was from Egypt, and some in Egyptian mummies they even found some evidence of calcification of vessels in the mummified remnants. And the Ebers papyrus says treated with fire and treated with fire. So they predated Bowie in their understanding of cautery. And Antyllus was the first person who actually took a proximal control, distal control, and then excised the aneurysmal sac and packed it. And for many centuries, there wasn't much in terms of development and treatment of aneurysms till John Hunter, who first identified the presence of collaterals after ligation of a vessel. And he is the first to have demonstrated a successful SFA ligation to treat a popliteal artery aneurysm. And if the records are to be believed, the patient survived with no loss of the limb. Rudolf Matas was another surgeon who operated on aneurysm of the periphery, but he was also the first surgeon to successfully ligate the aorta. And his record showed that the patient survived for 18 months after that before succumbing to tuberculosis, nothing related to the vascular. Bigger was an American surgeon who in the 1940s at the American Society of Surgeons showed that he did a survey among many surgeons and said most surgeons are extremely afraid to operate on diseases of the aorta. And Charles Dubos was the first person to introduce a prosthetic graft to be used in place of diseased aorta. And DeBakey was the first person to introduce polyester and tested many grafts. And I mean, he is the father of vascular surgery as we know today. And Juan Parodi was the first person who incorporated this synthetic material on balloons in order to use them in diseases of the aorta. And almost 70% of all aortic procedures, the degenerative procedures of the for degenerative disease of the aorta, are based on these principles. So this is a portrait of John Hunter from the Royal Society archive, and this is the father of aortic aneurysmal surgery, as we know, DeBakey. And this is a picture of one parody, the one on the left below. So, definition of aneurysm, and this I think is quite often asked. Many of our professors are quite exacting in their standards when they want us to repeat the definition. So, an aneurysm is defined as a permanent, localized, or focal dilatation of an artery which has at least a 50% increase in diameter compared with the expected normal diameter of the artery in question. So, a study in Sweden, which did MR angios on 70-year-old men and women, showed that there are, and they tabulated that the mean measurement of the aorta with two standard deviations on either side, and divided that in, because there were differences seen in men and women, and divided that into the ascending, descending, supraceliac, suprarenal, infrarenal, and bifurcation, and gave the means with the standard deviations of each. So, for example, the infrarenal for men is 2.4 and for women is 2.2 with a standard deviation of 0.5 in men and 0.3 in women. And for peripheral aneurysms, so when you have the when we are trying to decide an intervention and we have to decide if the aneurysmal size is abnormal where compared to the aortic segment, it is these ratios. So, for example, in the ascending aorta in men, if the ratio to normal is 1:8, it warrants an intervention, and 1:7 in women warrants an intervention. So, similar studies have been done for the other peripheral vessels and visceral vessels also. So, diameters of the celiac is 0.5, SMA is 0.6, popliteal is 0.9, etc. And this is also from the Ad Hoc Committee on Reporting Standards for the SVS in 1991. By the way, the definition, this definition that we did, the permanent localized, that definition is also by the Ad Hoc Committee for the SVS in 1991. So, before we move into the actual classifications and the etiology, I'd like to talk about true versus false aneurysm. So, a true aneurysm is where all three layers of the vessel wall are involved. So, there is dilatation of the entire vessel. And false aneurysm or pseudoaneurysm is where there is a locally contained hematoma which forms from the disruption of the vessel wall. So, a pseudoaneurysm, as we know, has a neck and a cavity. And therapy for pseudoaneurysm is usually directed at either ligating the neck, closing the opening, or trying to thrombose the cavity of the pseudoaneurysm. Pseudoaneurysms could also be seen at previous surgical anastomotic sites because of loss of anastomotic integrity. So this picture on the left lower corner shows a pseudoaneurysm arising from the femoral artery. Femoral artery and external iliac artery most commonly occur because of percutaneous procedures or attempted percutaneous procedures. So this is a picture of a pseudoaneurysm which has formed at probably infrarenal aortic repair segment, and pseudoaneurysm has formed postoperatively there. And this is the axial image of the same pseudoaneurysm, where we can see the segment and we can see the large aneurysm also. So most of the aneurysms and their prognosis depends on their location and extent. But before we talk about that, a few other terms which are important are ectasia, arteriomegaly, and aneurysmosis. So if something has reached an intermediate stage of enlargement, that's called ectasia. So the artery is abnormally large, but it's less than 50%. So that would be ectasia. And arteriomegaly is when there's a diffuse continuous enlargement of multiple arterial segments, and they are dilated to greater than 50% of normal. So the definition of aneurysm did contain the word focal. So arteriomegaly is when it's not focal. So if we looked at the epidemiology, both arterial ectasia and arteriomegaly are associated with an increased risk of aneurysmal disease in the first degree relatives of affected patients. And aneurysmosis is used to describe aneurysms of several anatomical locations, or if it's a combination of aneurysmal degeneration in the setting of arteriomegaly. So morphologically, we know that there are fusiform, saccular, and eccentric saccular aneurysms. I'll just skip to the picture. So this is a fusiform, concentric saccular, and eccentric saccular. So we call something fusiform when there's a generalized increase in the entire diameter of the affected vessel. And their true degenerative aneurysms are most likely to have a fusiform configuration. So in general, fusiform and saccular aneurysms, that's concentric saccular aneurysms, are because of generalized weakness or generalized thinning out of the vessel walls of that segment. Whereas eccentric saccular are usually because of an issue or a defect at one particular point. So saccular are often localized and they may be eccentric in shape. And eccentric saccular is because of defects arising from a focal ulcer or weakness in the arterial wall, very often due to trauma or infections. And so say for example, if due to hemodynamic stress, if there is an aortic ulcer at one segment, and if the intima is delaminated, and that if it doesn't get propagated and doesn't form a dissection, that area will probably form a saccular, eccentric saccular aneurysm. So the etiology are multiple factors. So degenerative, the terms degenerative and atherosclerosis are quite intermixed, and it's the most common form of aneurysmal etiology. And the relationship is complex because in the same patient, and the levels of proteins in the aneurysm are high. Another factor could be because of the deficit of an antiproteolytic enzyme, which is the inhibitor of metalloproteinase 1. And the intensity and degree and duration of cigarette smoking are also seen to be an important factor in the promotion of aneurysmal degeneration. So inflammatory is quite a foxing condition to understand and deal with. And here it's because of the exaggerated inflammatory component which causes a tissue response and incites a fibrotic response around the aneurysm. And the infracriminal aorta is the most commonly affected by this process, and imaging usually shows a rind around the exterior of the affected vessel, which may or may not envelope the adjacent structures. So if it is infrarenal, it can cause a ureteral obstruction, and genetic susceptibility have shown similarity between degenerative and inflammatory aneurysm. So we'd always tend to think of degenerative and inflammatory aneurysm as two different etiological processes, but the genetic studies have actually shown that they have more similarities than differences. And if we actually study the cytokine levels and the cellular infiltrates of the inflammatory aneurysms, it might lead us to better treatments. And surgically, it's quite hard to deal with them because of injuring the adjacent structure. So while doing a Hopper maneuver, you could have a duodenal perforation, we could have a ureteral injury. And it is seen that endovascular repair causes regression of the perianeurysmal inflammation and fibrosis. So the etiological factors of arteritis that are like all medium vessel and large vessel arteritis, Takayasu, giant cell, polyarteritis nodosa, Behçet's disease, Cogan syndrome, and cystic medial necrosis. So the surgical challenge, as I mentioned, is this, and so this CT shows that there is a rind around the infrarenal aorta. So very often aneurysms are associated with arterial dissection. So dissections in the aorta are quite often spontaneous, and if there is a spontaneous tear in the intima and propagation of the tear along the subintimal plane, that can cause a dissection. But if it doesn't propagate, it can cause a penetrating aortic ulcer and an intramural hematoma. And if the arterial pressure is high enough, and if there is acute arterial dissection because of the mural delamination, that can cause propagation of the dissection. So they may be symptomatic and they may present with symptoms of dissection in either the ascending or the descending aorta. So here the structural integrity is important, the three-layered structure of the blood vessel. The occlusive symptoms, they can present with either occlusive symptoms and subsequent aneurysmal degeneration. So aneurysm degeneration results from dissection. It can either present as acute rupture or it can be chronic. So chronic aneurysm due to dissection are treated on the same guidelines for size, growth, and symptoms as the ones used for degenerative aneurysms. So So another important cause of aneurysms is trauma, and aneurysms that result from trauma are pseudoaneurysms more commonly because of a perforation in a vessel. So the vessel will arrest the bleeding by local containment of the hemorrhage, and so the more the extremities are more prone to pseudoaneurysms and traumatic aneurysms. So they could also have developmental and congenital anomalies. So embryological defects such as it's either primarily vascular or it could be a coexisting with some other anomaly. So the persistent sciatic artery, which is seen in about 1 to 1.5% of the population, is always seen to be on about 40% of patients with persistent sciatic artery seem to have aneurysmal degenerations. The coronal diverticulum is another diverticulum where you have a aberrant origin of the right subclavian, and this could also be a cause of dysphagia lusorum when it winds around the esophagus. So, if the coronal diverticulum is also a form of aneurysmal degeneration, is also another location for aneurysmal degeneration. Congenital AAAs are seen in neonates with tuberous sclerosis, and the incidence of aortic aneurysm increases after the age of 65, and it is almost seen to increase by 6% with every decade. Though aortic aneurysms themselves are not a genetic condition, the prevalence in the general population is 5%, but in male siblings of a patient who has an aneurysm, there's approximately a 20 to 30% chance of existence. So another cause of aneurysm and pseudoaneurysms is causes. It could be because of hematogenous seeding, so a septic focus elsewhere, infection in the bloodstream from endocarditis or sepsis, and that could be hematogeneously seeded, or an adjacent infectious process, very often seen in infected pancreatic necrosis or infected pseudoaneurysms. And if many bacteria are responsible, especially Klebsiella, and very often non-fermenting gram-negative bacilli and nosocomial infections, fungi such as Candida and Aspergillus are also seen to be implicated. And tuberculosis and syphilis, of course. Syphilis, as we know, because of obliterative endartitis in the media, causes degeneration. So the incidence is, and very often it's seen in illicit drug abuser, patients who take injections which are unsterile. And the surgical treatment is complicated by the fact that we have to use antibiotic impregnated prosthetics. We cannot use normal other prosthetic devices, and we'll have to use biological. So this is an image which shows a infected pseudoaneurysm. So specific vessels, we're talking about the incidence of aneurysmal changes in specific vessels. So in the ascending aorta, the most common cause of aneurysmal degeneration it's because of degeneration or sequelae of a prior dissection. But in the arch and descending aorta, it's more often aneurysmal disease. And in the infrarenal location, AAAs are at least 9 times more common than thoracic aneurysms. So thoraco-abdominal aneurysms are seen in about 9% of cases of AAAs, but isolated thoracic and isolated AAAs are more common than thoraco-abdominal. So iliac is most commonly in the common iliac. It's quite interesting to note that only about 11 patients present with isolated iliac aneurysms. That means the remaining all 89% of patients have infrarenal plus iliac. So internal iliac aneurysms are the next most because of their deep nature and because of the vague presentation of their rupture, they can present as a rupture in 40% of patients, and it's almost a 30% mortality rate. So someone is able to figure out the cause of the bleeding. External iliac aneurysms are quite rare, and they are associated mostly with trauma or other non-degenerative causes. So, non-existent occur if they are more than in 26% of they will be bilateral, and 88% of patients have a synchronous aneurysm at another site. So pseudoaneurysms are most common as a complication of percutaneous femoral access or disruption of higher surgical bypass where the inflow is taken from the CFA. Using ultrasound guidance might help. So this figure shows us the concomitant existence of bilateral and the other locations such as the internal eye, the femoral and popliteal. So in terms of frequency, after popliteal comes the after infrarenal comes the popliteal, then comes the femoral, and then comes the iliac. So it's the most common peripheral arterial aneurysm, and it's seen almost in 1% of men aged 65 to 80 years of age. And they are frequently bilateral, and you should always screen for infrarenal aortic aneurysm if you find someone with a popliteal aneurysm, because almost 49% of patients will have a concomitant infrarenal AAA. So primary morbidity is if it gets thrombosed or if it embolizes, which can cause limb ischemia and hemorrhage. Visceral aneurysms such as the splenic aneurysm, it's seen in 1% of the population, and splenic aneurysms are the most common in the intra-abdominal cavity, and they account for 60% of all the splanchnic aneurysms. They are frequently seen in women, and they are in pregnancy they are seen to have a higher risk of rupture, and they can be managed with endovascular techniques such as endografting or embolization. And if it's an aneurysm involving the high limb, laparoscopic splenectomy can be performed. So the renal circulatory bed is characterized by low resistance and high flow characteristic, and that's why you can have very often you can have renal aneurysms. They are often saccular rather than fusiform because they're associated with fibromuscular dysplasia. Other connective tissue disorders, arthritis, trauma, and spontaneous dissection are also seen. So the sequelae of renal artery aneurysms include thrombotic and embolic events, poorly controlled hypertension, and rupture. The risk of rupture in the third trimester of pregnancy is seen, resulting in maternal and fetal mortality rates of 70 and 100%. So you would repair a renal artery aneurysm if the size is greater than 2 or 3 centimeters, if it occurs in women of childbearing age, if there is refractory hypertension, if there is flank pain or hematuria. And the size is not based on rigorous data, and it's seen that very often the management is quite aggressive in patients in whom this is detected. And they're amenable to both endovascular and open surgical reconstruction based on the disease process and the age of the patient. So cerebrovascular intracranial aneurysms, as we know, is quite a favorite by interventional radiologists and neurosurgeons. As such, and their arteries are rarely affected by aneurysmal degenerations, and the few that do occur in the carotid, commonly the internal followed by the common, and the external in decreasing order of frequency. So dissection which occurs after trauma can lead to late aneurysmal degeneration in both the internal carotid and the vertebral artery. Subclavian aneurysms can be as a result of thoracic outlet syndrome, and iatrogenic brachial pseudoaneurysms are seen as a consequence of percutaneous punctures and access. So multiple aneurysms are seen in the aorta and in the periphery. So in the aorta, also have abnormal negative aneurysms. And patients connected tissue discount higher incidence of multiple other aneurysms. And these are closely so that they don't develop aneurysm in other places. So this shows the incidence of multiple aneurysms that can occur. Popliteal aneurysm is the most frequently occurring one, as already said, and synchronous and metachronous can, I said, and 49 had coexisting AAAs. And many aneurysms have a 30% increase in having an aneurysm, so they should always be screened. And this is also true for triple aneurysmal degeneration should be screened with aneurysm syndrome, and presence of a bicuspid aortic valve is Turner syndrome is also seen to be associated with ascending aortic dissection. Thank you for your patient listening.